Welcome to the Global Addiction Therapeutics Innovation Day.
So everything that we do, be it old or innovative, is really aimed at making lives better for people affected by addictions. So it's very crucial to have perspective of people with lived experiences of substance use. I'm very pleased to invite our next speaker, Anton, who represents the INPUD, International Network of people who use drugs. His perspective will be crucial for us.
Thank you. Hello, everyone. Good morning. Yeah, Ahmed, it was a bit scary from patient perspective to look at that pictures of this new equipment, I should admit. Yeah, very interesting. So, my name is Anton Basenko, and I'm originally Ukrainian. Now I'm based in Brussels in Belgium, and I'm here representing the international network of people who use drugs. INPUD. I also speak from my lived experience as a person who used drugs for more than 25 years. Living with HIV openly, with lived experience in hepatitis C, and being a part of the global. Ah, sorry. Yeah. Oh, okay, it's me. And this is me. Okay. And being part of the global harm reduction and treatment advocacy movement for more than 2 decades. Who we are, INPUD. It's the only network of its kind. It's the global network of people who use drugs. Initially, many years ago, we had individual membership, but since then, at some point, we realized that it's impossible to be a global network and manage the individual membership across the world. So, of course, for now, our members are 8 regional networks of people who use drugs. So in every region of the world, we have a network, no matter whether it's a Pacific region, Middle East, Northern Africa, Eastern Europe, Central Asia, Africa, Northern America, and international network of women who use drugs. So it's 9 members, which are members of INPUD. But we also have connections through regional networks or directly with country networks of people who use drugs. And this is very a rising area, because community on the ground really going through the processes of, structuring, mobilization. Well, what to say? Our mission is very simple but urgent: to challenge stigma, criminalization, and exclusion. We advocate for the health, rights, and dignity for all people who use drugs, and we work across policy, harm reduction, HIV and hepatitis C, as well as viral hepatitis agenda broader, and treatment access. But let me tell you about myself a little bit. So I'm 45 now. I was born in 1980, so as I said, I'm from Ukraine. In a certain sense, my story is atypical for my generation, and at least for my country in Eastern Europe. So I started my experiments with drugs when I was 14. It was mid-90s. So you can imagine it's a few years after collapse of Soviet Union. It's a totally new reality for families in countries like Ukraine, for teenagers like myself. Of course, what we know from science, that average age of starting the experiments is like 15, so I started in 14. So yeah, I'm very close to that age. I started from stimulants because I was involved in night club industry as a DJ, and it was also developing area. But with this area, of course, many new substances came to the country. Of course, teenagers and people like us, we didn't know about potential risks. It's just new things, so cool. We're experimenting, we're having new experiences. Yeah, and actually from there, that's how at some point I tried heroin just as a sleeper, because I couldn't sleep well after nights spent in the nightclubs working and using the stimulants all the time. So, but that was my opioid trap, as I said, and from there, like, opioids really squeezed out all other substances from my life, and I spent a lot of difficult years on heroin, on other opioids, because for countries like Ukraine, our drug scene is a bit different. We have a homemade opioid because poppies, it's a traditional plant for countries like Ukraine, so it's not heroin on the streets. It's something what we cook, what we can cook from the poppies at home. But you can imagine the quality and the level of cleanliness of this substance. So of course, lots of health conditions coming with the systematic use of these drugs. Well, of course, I went through the number of overdosages. I have problems with law enforcement. I lived on the streets. I lost normal connections with my family and friends. And what's important to say, I counted around 50 attempts of different kinds of treatment. Why I'm quoting treatment, because then later I realized that part of what's been proposed as the treatment, it's far from science. It's not treatment. It's just people who realizing that, this family, they are going through these, challenges. They're looking for help. They're ready to pay any money just to save their kid, for instance, to save his life and health. And they're just doing their, business on these fake treatments. Thanks God, in 2004, so since 2003, I become a client of harm reduction, needle and syringe programs, and it's good because this is really an entry point to connections with different services. Unfortunately, I've been diagnosed at the same year with HIV and hepatitis C. It was, of course, it sounded as a death sentence because, again, at that moment I was not aware about all this, information. But what's worked in my case, so in 2004, Ukraine started pilot projects on opioid agonist therapy. We started from buprenorphine. It was just a part of our advocacy strategy because this opposition to methadone, to the word methadone, everyone was so, oh, methadone. What to say, on the public meetings where, different NGOs were trying to kind of advocate for bringing the methadone to Ukraine. At that moment, chief of drug control department of Ministry of Interior said, the one who will import methadone to Ukraine, next day I will imprison you. So can you imagine a person saying this publicly? And of course, when specialists, experts like you sitting in the room, you can imagine the impression. So we started from buprenorphine, and I was among the first lucky 30 patients in Kiev, and that really not just stabilized me, but it really saved my life. And since then, I've gone from being just a patient and a peer worker, because at some point I started to, share my life experience with other guys and work on the ground root level, helping to involve people in treatment. At some point, we organized the first national network of opioid agonist therapy patients in Ukraine, and then later I was a founding member of the Ukrainian network of people who use drugs. And actually, I became also working as a professional in the Alliance for Public Health, which is a leading civil society organization in the Eastern Europe, Central Asia, working in the HIV, tuberculosis, and viral hepatitis field. This organization covers the largest harm reduction and OET program in the region of Eastern Europe, Central Asia. And if we take the Global Fund funds, it's the largest in the world. So on one hand, I was like, with my expertise working in this organization, but being the person with lived experience, with a sense of activism, with this, motive to help as much as I can to my peers, we went through the different transformations, and finally now you can see me as Executive Director of the International Network of People Who Use Drugs, and just a few pictures from the activities we do on the global level, UN level. And what to say, this journey is not unique. It's happening across the world, but it proves that lived experience is not anecdotal, it's real evidence. Why lived experience matters? Well, innovation is definitely more than just molecules, patents, it's about people. And people who use drugs are amazing experts in surviving broken systems, in identifying treatment barriers, and designing services that actually work. Let's take peer-led harm reduction and community-based opioid agonist therapy. These weren't invented in labs. They were born out of necessity, built by people with lived experience, and later adopted into public health system because they work. But talking about innovation gaps, what we as community see. First of all, first example. Well, maybe shame on me, but when I received the invitation from Hamed, I didn't know about ISAM as organization. I asked my colleagues on some call from WHO if it's a real organization, and seriously, I was sure that it's some maybe, you know, sometimes fake invitations coming like just to take your personal data or something like that. Well, I'm very sorry, but then I realized that it's something. It's a really good sign, you know, how it's about visibility of organizations like yours, and it's about connections between organizations like ISAM, and organizations like INPUD and community. Because if we're talking about innovations, it's impossible, you know, to really be productive and effective without building this partnership with people for whom these innovations are invented. So in many countries, unfortunately, we can't even access basic things like needle syringe programs, opioid agonist therapy, naloxone, PrEP, pre-exposure prophylaxis of HIV. Unfortunately, harm reduction is still defunded or criminalized. I mean, defunded from the national governments, well, as of course, globally, because donors' funding is also shrinking. Unfortunately, I should say that there is still, we observe conflict between abstinence-based philosophy treatment programs and harm reduction philosophy, including medical-assisted therapies. Maybe it's not the case for some countries, but unfortunately, we can see that on the community level, we found some, you know, agreement as a community. No matter what is your experience in treatment, no matter whether you are using now or you just have experience of being user, we are still facing with the criminalization, with the stigma and discrimination. We are sharing same scope of problems, so that is our uniting factor, and we are welcoming people with lived and living experience. That is a very important thing, because my presentation is just about lived experience, like in the past, but in fact it's more important, or important to understand that it's also living experience of people who are using now. Compulsory treatment centers, or so-called sober houses, it's an issue. It's a trend we hear from Africa, from MENA region. Innovation often fails to reach the people who need it most. We know, like, innovations even in HIV field, or for instance, long-acting forms of buprenorphine. It's expensive thing, you know, and well, the speed with which these innovations reaching then the people in need on the ground is very long. And when we are on the last track before achieving sustainable development goals in 2030, like the last 5 years, we should really be, you know, creative on how we are moving forward. So digital tools, unfortunately, often designed without input from the very users that aim to help. I'm not saying about necessarily applications which have been presented here, because with WHO and UNAIDS we have a very good collaboration. So there is still a wide chasm between scientific development and community reality. Community-led innovations, just a few examples. So peer-led low-threshold opioid agonist treatment models in Ukraine, Kenya, Vietnam, community-designed overdose prevention tech, mutual aid during crisis, network and for instance, Ukraine, which is in the war, we transformed, and we know how to distribute meds and syringes even in this emergency context. And also, this is a very good moment where we realize the need in the long-acting forms, when person doesn't need to come every day to the OET site, and they can use just a monthly injection. And like things like telehealth, which is helping eliminating OET waiting lists in rural area in Ireland. Please, this publication, if you don't know how to work with people who use drugs or how to build the programs for and with and by people who use the drugs, this is I think the basic publication which you should use. Implementing, it named I Do It, is an acronym from implementing comprehensive programs for people who use drugs. So like, yes. The same publication exists for other key populations, so sex workers implementation tool will be SWIT, men's having sex with men will be MSMIT, and people, transgender people will be transit. But this is I Do It, and please use it if you just asking yourself, but what are the values for these people, what is important for them, how we can work with them. So barriers to innovation. We continue to be blocked by really structural barriers, criminalization, lack of legal protection, I mean not only patients but also prescribers, no funding for community-led research and design. Very, very good example been mentioned about UNAIDS funded project where a research project about long-acting forms of buprenorphine, loaded space needles in syringes, which is happening in 10 countries, and INPUD is part of one of the consortiums, and we are chairing community advisory board. So we've been involved in the methodology development. We've been there from the very beginning. Not like, you know, sometimes, oh, let's use community as just respondents in the trials or in some surveys. We really are in the decision-making process. We are on all stages. This is how such projects should look like. Legal barriers, unfortunately, repressive drug policies, and this concept of war on drugs is still there. Hopefully, after last commission on narcotic drugs and leadership, under the leadership of Colombia, they reached some changes, some resolution which helped to reconsider the conventions and this concept during the next 2 years. I hope for really better future. And talking inclusion, where we are invited into conversation but excluded from decision making. So if the goal is innovation with impact, these barriers must be dismantled. What we need, include people with lived experience from the start, as I said, in designing, testing, delivering solutions, fund, co-create pilot projects and scale what works, like I just mentioned this UNAIDS project as example, create pool funding mechanisms that support community-led innovation, and reform drug policy so access and equity aren't blocked by outdated laws. And my final message. Our motto as a community, nothing about us without us. But it's not just a slogan. It's a scientific and ethical imperative. Innovation that excludes is not innovation. If we want to truly transform addiction treatment, we must co-create it with those who have lived and living with it. Thank you.
Organized by International Society of Addiction Medicine, sponsors and co-organizers, CNRE, Indivir, Spark Biomedical, Salofa, Ethifarm, University of Minnesota, European Union Drugs Agency, UK Office for Life Sciences,